Good morning, good afternoon, good evening, everyone. Welcome to the Innovations in Healthcare COVID-19 Learning and Action Network talk for today, September 23rd. We're just going to give maybe a couple more minutes to let everybody get logged on, but in the meantime, maybe I will talk a little bit about our agenda today. We got an exciting agenda planned. We have a panel, Shifting Models to Home-Based Care During the COVID-19 Pandemic. We'll spend about 45 minutes talking to our guests, which I'll let introduce themselves in a few minutes. And then we're going to leave plenty of time at the end for question and answers. So that's the panel is going to be the sole topic for today. And then we'll talk, we'll maybe open up to the floor to see what other topics, the network might be interested in exploring next in October. So just some general guidelines. Please keep your mic muted and your video off when you're not participating. Use chat at any time to add a question or comment. Feel free to unmute yourself and speak up and ask a question during the panel or certainly afterwards. Just as a note, this is being recorded and will be posted to the call topic groups.io and also on our events page at innovationsinhealthcare.org. And please keep the conversation going on the listserv. That's why we created the group. You're all members of this Learning and Action Network, and we hope that we can continue with that. I am, I'm not sure, we may be waiting on Dr. Lantum, but let me go ahead and introduce the panel. And I would ask that our panelists introduce themselves. So let me say first off, welcome to all of you. Thank you so much for joining us. I'm having there we go. Thank you all for joining us this morning or this afternoon, as the case may be. Very excited to have you here. Dr. Kimani, could you tell us a little bit about yourself and your organization?
Good morning, good afternoon, everyone. Can you hear me, Jude?
Yeah, yes, we can hear you. Please, go ahead.
Okay. Great. Good morning, good afternoon, everyone. My name is Dr. Maureen Kimani. I head the Division of Community Health at the Ministry of Health. I'm also the team lead for the COVID-19 community engagement and also implementing the home-based care program, which has been quite successful in Kenya, especially in our 2 high-burden COVID-19 counties. So I'm happy to be part of this panel, and I want to hear more. But for us as a ministry, we really want to move the home care program beyond COVID-19. So it's one of our post-COVID we hope to scale up. Thank you.
Great. Well, welcome. Thank you so much for joining us this morning. I believe Mocha, are you on the line? I believe we're still waiting on Dr. Lantum. So let's give him a minute to connect. So Miguel, can you introduce yourself and tell us a little bit about Clínicas do Alto?
Sure. Thank you, Jude. Hello, everyone. Good morning and good afternoon. My name is Miguel Garza. I lead the business development department at Clínicas del Azúcar. Clínicas del Azúcar is based in Mexico. We are a one-stop shop, a retail model for diabetes care. We have been in the market for 8 years. And we have now 16 clinics throughout Mexico, in the north and in the west. Actually, on Friday, we opened clinic number 17, so we're very excited for that. And we are now glad to say that we are now the largest private provider of private diabetes healthcare. So excited to be in the panel. Thank you so much for the invitation, and looking forward for the questions that the panelists and the audience may have.
Congratulations on the new clinic opening. That's great news. Monica, are you with us? Can you tell us a little bit about yourself and Penda Health?
Happy to. Hi, everyone. I'm Monica Day. I am the Global Partnerships Manager at Penda Health, which is a Nairobi-based network of outpatient medical centers located primarily in urban and peri-urban Nairobi. And actually, at the moment, we also have 17 centers located around the Nairobi area. So I'm excited to learn more from the panelists and for this conversation.
Excellent. Welcome. Thank you for joining us. I'm just checking the guest list here. I think Dr. Lantham may be having issues joining. Mocha, are you on the line?
I'm here, Judd. How are you doing?
Okay. Excellent. Thank you. Thanks so much for joining. Please, if you could introduce yourself and tell us a little bit about Sagittarius for the audience, that'd be great.
Fantastic. Thank you. I just got off a Sagittarius meeting back to back. Yes, my name is Mocha, and I think the title of CEO may be a little wrong. It is the Chief Executive Hustler, so it should be CEH. Because really, we hustle every day to get medicines as fast as we can at the best price to our customers, who are mostly low-wage workers working with some of the big corporations. And these are persons who, because of the time constraints imposed by their job category or because of their location, having access to medicines or care for very common conditions becomes a challenge. And so we have specialized our need around supporting them in that effort. And to do that, we have clinics that serve as dispatch locations for either medicines or teleconsultation or lab services. And so we're very mobile, we're very agile, and we're very competitive. And we are currently in Nairobi and South Sudan. And our model is primarily based on relationships or partnerships with the insurance companies or the companies, the companies that employ a large population base of low-wage workers. And our impact model is really early detection and treatment of disease and cost savings per prescription. And so far this year, we have served over 25,000 homes. We are on track to save households over $200,000 on medicines. And we, on average, is 20% on medicines, 30% on labs, and about 40% on diagnostics. Thank you.
Again, welcome. Thank you. Welcome to all. Thank you so much for joining us. I'm sure we'll have a very interesting conversation this morning, as you know, about home-based care and the transition to it due to the pandemic. And as Dr. Kimani said, you know, potentially shifting to these models on a more permanent basis, as you know, on the other side, whenever and wherever that may be. So I guess my first question is for the innovators. And I'd like to hear your thoughts and observations on the nature and scale of the problem you're facing at your particular organization. So to what extent has COVID forced you to change where and how you deliver care? Are there certain constituencies or service lines that have been partially affected or particularly affected, or has it impacted your care delivery model across the board? And what factors are driving these changes? Is it strictly adherence to social distancing protocols, or secondary considerations such as access to transportation or limited ability to leave the home because of obligations such as childcare? Mocha, do you want to start off first and try and answer that question? Sort of what's the extent of the impact and how's it impacted your operation?
Sure, Judd. Thank you. And hi to Maureen, Miguel, and Monica. I didn't get a chance to say hi in my opening remarks. I think if you think about primary healthcare as has been developed and promoted for years, where we were championing barriers to care, that whole notion and context was fundamentally rooted in the notion that it was okay to leave your home with whatever condition you have and come to the hospital setting, sit on a bench, butt to butt, shoulder to shoulder, wait for 3, 4, 5, 6 hours, and you shall be seen at some point. Then at some point you would see a nurse who is unmasked, and she would touch you and come in very close contact in the name of collecting your vitals. And then you would proceed to another location, and you shall see maybe a lab person who is unmasked. And then you shall go back to the doctor's office, who shall see you again and then prescribe. Then you shall go to a pharmacy and then get your medication. And then at some point in time, go home. In that process, the duration of care is lots of hours, 6 hours, in closed rooms, in close proximity with patients or providers. That is primary healthcare as we knew it until March 15th, 2020. That model is no longer valid. That means, in a way, the global health agenda is in a position of a checkmate. The primary healthcare facilities that form the backbone of public services and to a large extent private services now no longer are safe. And so we need to now re-educate ourselves and re-educate the market as to the fact that what we thought previously was optimal is pretty much suboptimal, especially within the context of transmission of infectious diseases. Secondly, that puts into question two fundamental questions. Now, if we are telling people not to come to those facilities, what are we doing to reach them at home? That puts into question, if we say teleconsultation is a mode of engaging in primary healthcare going forward, then what happens to persons who need, who don't have the data to connect by video calls? What happens to people who don't have the fundamental understanding of how to be interrogated over the phone for something as important as healthcare? So there's a seismic shift in terms of what we need to emphasize and what would be the new barriers of access to healthcare at the primary healthcare level. And I think it's imperative that we embrace that reality. And it may mean that a lot of capacity that we have would no longer be necessary for primary healthcare. It may mean that we may need to start thinking about investing in telecommunications at a very different level than we had thought about previously in public settings. So I'll leave it at that for now and maybe allow others to weigh in on the question you just asked. Thanks.
Thank you, Mocha, for that. Miguel, can you tell us how the pandemic has impacted your operations?
Sure. So basically, it impacted in 4 fronts. Like the rest of the world, in Mexico, from one week to another, everything changed. And the first impact that we saw was since we were considered an essential business, we had to continue operating, and it was very expensive. The first challenge was we had to acquire and to purchase all these safety equipment for all our personnel first, and also for patients in case they did not come with the right equipment. So that was the first challenge. Then at the other on the other side, part of our model or the one of the essential parts of our model is to have back-to-back consultations in our clinic. The more patients we see, the more profitable the model can be, and the more clinics we can make. So the second challenge was, how can we space out the consultations, because we knew that we could not have a large amount of patients in our waiting rooms, and also typically one patient would go to the doctor, and maybe one or two family members also joined the consultation just to make sure if they had any questions or if they had any follow-up answers. And we also had to prevent that. So managing the volume of patients in the clinic was our second challenge. And then in terms of, how the city or the state and the country started to act with regards to the pandemic, one of the things that they started to do during April, May, and June was, well, we're going to lower the amount of public transportation that is given throughout the city, no? So that also impacted, well, not only the patients, because a lot of our patients move through public transportation, but also some of our employees and staff and medical staff that go to the clinic. So that was another challenge that we faced during the first months. And finally, I would say that as you mentioned in the question, childcare facilities also closed the week that this all started. And that had a huge impact on our employees. We have a lot of staff medical staff specifically, that leave their children at childcare, and now they couldn't. So it was also not only a challenge towards our operations, but also towards our patients getting to the clinics with the right safety measures. But then at the other side, it was also a challenge for our staff to actually get to the clinic and continue operating. So it was quite challenging for those 2-3 weeks that everything changed. But on the other side, I would just add before continuing, since we are specialized in diabetes, and as you all know, one of the recommendations when COVID-19 started was stay at home, specifically if you have diabetes or hypertension, because those are vulnerable diseases that if you contract COVID, it would possibly lead to complications. So a lot of our patients, or I would say a lot of people that have diabetes that did not want to get treated, now started to get worried and wanted to seek care. So at on the one side, it had a lot of impact on the operations, but on the other side, it created a lot of awareness in terms of, if you have diabetes, get care, because if you get COVID, it could lead to complications. So it was an exciting, I would say, and in terms of complications, but also on opportunities. The first 2 months of the pandemic, so April and May. I would stop at that, and then we could continue on some of the things that we started to create around that.
Yes, great. Thank you. So, yes, it sounds like issues across the board from patients and the providers, but different attitudes towards treatment as well. So, Monica, can you tell us a little bit about Penda Health and the impact that COVID's had on your operations?
Absolutely. So I would echo a lot of the same things that that Mocha and Miguel said, in terms of just an impact on wanting to make sure that we could keep our medical centers safe and open. So making really big investments in keeping our staff safe. So purchasing a lot of PPE, which would allow us to actually keep our centers open. So that was really, at the beginning of the crisis, our first priority, because if we didn't do that, then we couldn't actually operate as a healthcare provider. In addition to that, so not only keeping our centers open, but we've also, given that people really are scared to leave home in many ways, and especially to come to medical providers, where their perception is that they may be more likely to actually contract COVID-19. One of the big challenges has been trying to reassure patients that actually we've taken all of the necessary precautions to keep them safe. So, and especially when this comes to patients that we consider a little bit more vulnerable. So children that need to be vaccinated, mothers that need to come in for prenatal care, patients with hypertension and diabetes. Those have been really our main priorities in making sure that we can deliver care to them in the safest way possible and encourage them to both come into our center, but then also access care virtually. So I know I'll get to that at another point, but we've also been doing a lot of experimentation and trying to figure out the way to make virtual and phone-based care actually work for our patients.
Excellent. Thank you all. So I guess my next question then would be for Dr. Kimani. What has been your perspective from the Division of Community Health Services on the impact of care delivery models? Has this been an adjustment in the way that care is delivered or a fundamental shift in the way healthcare is accessed?
Thank you, Jude, and hi to my fellow panelists. So obviously, yes, after March 15th or 13th, when we got our first case, what immediately happened at the community, because that's where we deal mainly, is that we started doing some knowledge, attitude, and practice surveys just to see how people were dealing with the new situation, what were the emerging issues, and some of the main emerging issues was around access to care, especially in the primary healthcare facilities, where there was a sharp decline in outpatient visits in most of the public sector facilities, as well as, of course, in the private sector. And then some of the things communities were talking about was that they were scared, they were afraid. Of course, there was a lot of advocacy around stay at home, do social distancing and all that. And that certainly impacted, especially the people who had chronic conditions and who probably need to regularly go to health facilities. So certainly that was an area we saw, and that was around towards the early, and immediately there were interventions that were put across. So for us at community level, we actually came up with some policy guidelines or direction to health facilities. Their patients, if they could not access care within the clinics, then that care could be provided for them at home, especially for patients with diabetes, patients with TB, and HIV patients. So I think that was one of the areas we really had to act quickly. And maybe just to give a background about community health in Kenya. So we have a population of about 47.5 million people, and we expect to have about 9,500 community health units, which take care of about 5,000 people. So these community health units work very well in the rural and the peri-urban areas, but then doesn't work so well in the urban areas. And so in these areas, what we increasingly saw was the use of telemedicine, and there were many other innovators beyond Penda and I think the other Mocha, who started giving telemedicine, supporting patients right at home. So the doctors would actually, there was a hotline where patients would call and a doctor would actually visit them at their home. Again, this was something that was already there, but then before COVID, it actually had not come to be known by a lot of the population. But I think because of COVID, a lot of people preferred to have services being brought closer to the people. So actually what I see as moving to is more people-centered care, moving nearer to people's homes. Again, we know the advantages that are there if people have suitable residences or homes, that we can actually do a lot of the things that we admit patients for in facilities can actually be taken care of at home if we give proper guidance to the caregivers at home, and also have a very clear channels of supporting and follow-up from the health facilities. So again, that was an area that we saw quite a bit of innovation. And then the other thing was issues around the use of technology. Again, during time, there's been a lot of use of technology to support, to either to give information to patients or to give even information to caregivers around availability of health services, or where they can, access to referrals, which before COVID, that was not something that was actually widely practiced as during the times of COVID. The other thing is that the government also introduced a hotline. The hotline mainly was with one of our biggest telco, Safaricom, and it was mainly to support patients get information on COVID, and if they had any symptoms, they could report, so that maybe the ambulance could quickly come to evacuate them to an isolation facility. But then what we saw is that people actually moved beyond asking questions about COVID, and they were now asking about general health issues that they had and where they could seek care. So that even led us to actually hire about 50 medical officers, and they were now stationed at the call centers in the telco company, Safaricom, so that they could actually respond to some of the medical questions that the people kept asking. So these are some of the innovations we see as being very good, and which we can actually, in terms of, as a country, we're really moving towards universal health coverage, bringing services closer to the community, empowering communities to take charge of their care, not just leaving it all to the health facility. And therefore, I think this is one of the areas that post-COVID, whenever that happens, or even as we move towards, as we continue with the response to the pandemic, this is something that we really see as a good practice that we have learned during this period as government. And this is something that would really want to scale up so that we are sure that people can be able to access care. The other thing that came was that as a country, we also introduced night curfews. So there was a curfew from 7 p.m. to 5 a.m. in the morning. And obviously, after the curfew was put in place by the president, of course, there were some challenges because of the patients who required to access care at night, mainly children, pregnant women, and so forth. So we saw quite some shift in terms of what people are able to do with what the existing infrastructure. For example, using the Uber kind of taxis to actually support the mothers who require to go to facilities, but they were unable to because of the curfew measures that were in place. Organizations came together, the private, public partnerships, and put in place an Uber kind of referral system where a mother could call a hotline number, which would easily come to their place, and they would be evacuated for whatever emergency medical services that they required. So again, that's another innovation that we see that will probably help us in the future, because our referral system was not so good before, but with all these innovations coming into place, with all the public-private partnerships that have been born because of COVID-19, then we see this as helping us to actually overcome some of the referral challenges that we've had. And so what we have done as a division of community health is also to have lots of partnerships with private sector players to support a lot of these things, including the technology issues, which of course we as government may not be so strong on, and also to support ongoing advocacy using mobile health platforms to the public. And so there've been many like these SMS services that have been created, giving different kinds of information to different segments of the population. There's some for youth, there's some for even for healthcare workers where they get information, because what we realized was also that healthcare workers, as much as they were community members, they were trusted by their communities, but given the fact that they worked in facilities, what started happening is that their communities or their neighbors started stigmatizing them because, of course, they're from the facility and they thought you must have brought corona with you. COVID with you because you work in a health facility. So there was also some hotlines that were put in place to ensure that the healthcare workers have psychosocial support from virtually from somebody, so that they're able to cope with some of the issues and to know even how to respond to their neighbors when they are being stigmatized. So the other thing I'd want to say is that in terms of giving information, health information to the public, I think that's another area that we have seen lots of improvement during the COVID because we've been able to use a lot of the social media platforms to engage different segments who are able to be on social media using tweet chats, doing lots and lots of webinars, inviting different kinds of players to just come and share something that would help communities to be able to take care of themselves better. So I think that's another area which was not so prominent that has really become prominent at this time. And finally, at the policy level, what we have done at the community level, everybody comes to the community, doesn't matter the condition you're dealing with. And so we are just in the process of finalizing our 5-year strategic plan for community health services. And so some of these innovations, we have already put them in our strategy, and we are hoping that as we continue to move towards achieving our UHC agenda by 2022, we'll also be really looking at scaling up some of these good practices, which will help us actually achieve UHC and probably see improvement in our health indicators and, of course, better health for our people. So I want to stop there and maybe just maybe other people can say something. Thank you, Jude.
Thank you, Maureen, for that. I mean, it sounds like you went through a lot of different programs that were implemented, that were expanded. I guess they say necessity is the mother of invention. So I think a lot of things were in place, but timelines have been moved up, and other partnerships have been formed, and it sounds like a lot of positive change in the implementation of health, and it's particularly moving towards home-based care. So I'd love to hear from some of the innovators as far as what changes have happened at their operations. What things have you moved up? What new things have you found, or what parts of your operations have you expanded in response to this to move things, specifically transitioning to the home-based model?
So I can go first, Jude, if that's okay.
Yes, please go ahead.
So first, we decided to create a COVID committee as soon as this started, just to make sure we covered all the angles of the challenges that I previously mentioned. And the first thing that we wanted to make sure was the safety of our personnel, and also our staff and the patients. And during the second week of April, I remember perfectly, we started to see an increase in 700% the numbers of phone calls that we received to the clinics and centers. So going back to what I mentioned about awareness, as soon as this hit and diabetes was a main concern for the population, we started to see a lot of new patients that wanted to get treatment, and also current patients that wanted to see how they were going to get their next consultation. No, so the first thing that we did at the end of April, we decided we had not yet established the technology to make video consultations. But we do have the regular telephone, no? So we started to make consultations through a regular telephone call, and specifically mainly for doctor consultations, and also for nutritional consultations, and specifically for some patients that were more scared than others. I know that at least in Mexico, it has happened that some people are less scared of the pandemic and are willing to go out of their houses with all the safety precautions, and other patients or other persons are very scared and prefer not to leave home at all until all this is over. So we also had to manage and segment what type of patients we were dealing with, and we just started making consultations through the phone. Obviously, as Monica said, they were some patients. We wanted to tell the patients that everything was safe in the clinics. So the ones that wanted to come were very welcome to come. And then before all COVID started, our digital plans were going to start late 2020, early 2021. So what we decided in April was we need to fast track all our digital initiatives and make sure that we implement them in the next 2-3 months. So we started working as soon as we started giving consultations by telephone. We started working on the digital platform, our app, so that also patients can download, and also on video consultations. So now we are also able to treat patients through video conference, the ones that prefer that. And one of the things that we started to see was how will this shift or change be implemented or have an impact in the next 2, 3, and 5 years. So we also wanted to make sure that the initiatives that we started to implement were going to also work once COVID finished. So hopefully it can be by the end of this year or maybe mid next year. But we also wanted to make sure that all the investments that we did in our digital strategy were going to continue to work in a post-COVID world. So that was very important also for us. We now are able to make video consultations, as I mentioned, and we're starting to see an opportunity also in what happens if we treat patients through this virtual consultation or virtual clinic, that in places in Mexico where we do not have a clinic, and even in places in Latin America or in the US where they speak Spanish. So this has also opened an opportunity of a huge market in terms of diabetes care.
Great, thank you, Miguel. So it's again sort of expansion of opportunity that this caused, but caused some problems, but also opened some other doors. So fascinating. Is Mocha or Monica, do you want to comment on maybe how your operations have shifted and what you've done to address it, or any surprising implications of the implementation?
Yeah, I'm happy to jump in. Actually, very, very similar to what Miguel was saying. We had long-term plans of digital expansion and moving into different models of digital healthcare, and COVID really accelerated all of that. So right at the beginning, we launched a telemedicine hotline to be able to do free medical consultations over the phone. And we realized actually pretty early on that while some patients were calling us, there were still some pretty structural barriers to that happening. So for example, lack of airtime or data would cause patients to call us and then hang up really quickly, meaning that we would always make an effort to call them back. And so that kind of struck something in us that we needed to make digital healthcare really accessible to the masses. So one thing that we focused on is doing a lot of outbound calls to patients. So for things like reminders to refill their medications, especially for hypertensive and diabetic patients, reminders for families to bring their children in for vaccinations, reminders to mothers to come in for their antenatal care visits. So actually while we're still taking inbound calls directly from patients, we're actually, as of now, doing many more calls outbound, which is really interesting. And we're also investigating now different types of tools that we know our patients are already using. So things like WhatsApp and Facebook Messenger, where patients have already been communicating with us, and we're trying to figure out how that works well, blended with our in-person model of healthcare. So using digital tools to not only be able to provide advice, but then also referrals to our medical centers that are based around Nairobi. So actually creating a really, what we're calling a blended model of healthcare. Yeah, so actually a really an interesting parallel to the work that Miguel, you guys are doing as well.
Thank you, Monica. Monica, did you have? Yeah.
Yeah, I just wanted to share our experience at a very high level. Being at the front lines of COVID and primary healthcare was quite an experience. Before COVID, our primary mechanism for engaging our target customer was by going into the workspaces. And so once as the lockdown happened, we had pretty much cancellation of a lot of the planned events that we had built up. We expect, I think at the time we're projecting about 2,500 patients whom we had booked for services, and all of that was gone overnight. So there's that shock factor really. And so we kind of had to dig deep, and I sat with my leadership team, and my feedback was, let's not panic. In business, in times of crisis, that is when you go back to your value proposition. What makes you get up every day? What makes you want to do this? And we want to be clear about that. And once as we had that conversation, it became very clear to us that there was no better time than now for us to clearly showcase our value proposition, which was, how can we help everyone, especially those who rely on mass transit to get to work, those who are very price sensitive for care, those who typically have been constrained by their work hours in terms of when they get care. How do we serve them better now that they're at home with their families and they are scared of losing their jobs and so on and so forth? So we dug deep in our value proposition, deep as we could. And we said, we're going to try to reach out to every customer in their home and try to make sure there's continuity of service. And so what we then now decided to do was to say, okay, who is the best person to go to those homes, and how can we most efficiently get to those homes without adding to our overhead? And we partnered with freelance writers in the different estates, and we explained to them, we just had a conversation with a couple of writers, and we said, this is the challenge we're having, and we think you guys could be partners. And they immediately said, yes, we want to be part of this, because they too were experiencing a similar impact of the lockdown, whereby deliveries had dropped, And so their typical customers were no longer people who were they would either be shuttling to work or delivering goods to were no longer in need of those services. So I think that was a stroke of genius. And we certainly had the opportunity to partner with them. We trained them, we gave them the necessary PPEs, and the rest is history. And they set their own targets, and their targets are 60 homes a day per rider. And so far they've done more than 25,000 homes with a reasonable conversion. And we've been able to deliver medicines now to almost 1,000 persons during the last 3-4 months. So it's been really good. And talking about technology, and I think what Miguel and Monica were saying, obviously that also was a key part of the consideration. But what we realized in the riders is that they have tremendous capacity to manage technology on behalf of the patient. They have all the apps. They have Uber Eats, they have Safe Border, they have all those apps on their phones. So they are very app friendly. They love it. We didn't want to add another app, but they are just now a conduit. So they get into the home, they identify the patient, and then they connect them using their phone to us, and then we offer the teleconsultation, after which point if there's medication to be delivered, they do so. If they need to bring the patient to the clinic, they do so. So it's really been a good way for us to bridge the gap between those who can afford technology, those who are literate or comfortable doing teleconsultations, and then obviously there's the logistics of healthcare, which that solves. And I think it's something that would continue to be part of our service model in both Kenya and South Sudan, and we're seeing a lot of opportunity there. I just want to mention that, you know, we have seen 3 waves of issues at a very high level. The first wave was complete shutdown, no services. The second wave is like, wow, people now beginning to move, but infectious diseases have reduced by 85%. So even our traditional customer base has shifted by virtue of the reduced utilization. And then now the third wave is the back to work excitement. But then when one person at work is diagnosed as positive, the mayhem that comes with it. And so we are finding ourselves really playing a huge role in just information management. Actually, our teleconsultation line, we've received 1,800 calls, most of which are people just wanting clarification. So we have now made information management a very key part of our service offering. And it's at no cost to the customer, but of huge value. And we hope that it pays in the long term, pays off in the long term. So that's really it from our perspective, you know, how we're able to survive and stay afloat during this period.
Thank you. Thank you, Miguel. I mean, really, really innovative implementation with the riders model to bring care to the community, and also, as you noted, to bring technology to the community through their apps and their phones. I have a question from Don Goldman in the audience about sort of what proportion of the patients have phones with the apps. I guess to what extent is patient access to technology limiting implementation of some of these digital models? And I guess that's a question to all of the panel.
That's a great question. So in terms for us, at least in Mexico, I think it's around 70% of the population has now a smartphone, and obviously increasing in the next years. But I would say that obviously everyone has a phone. So for us, even if it was a video consultation or just a phone consultation, we were able to make the consultation. No? So just to answer your question quickly, I would say that around 80 to 85% of our patients now have a smartphone.
From my perspective, I've done a lot of house calls with the riders, and all households I've been to, they have a smartphone. I think the question for me is, and Monica talked about it, is do they have data? Do they, that's where they struggle. And then can their phone accommodate another app? It's almost like real estate where you have a piece of land, 1 acre of land, and there are already so many houses built, and to build one new house, you have to break down another house. That's really what we see as a challenge from the community level in terms of how they're looking at us potentially introducing another app to their phone versus the apps that they have. But WhatsApp works well for most people. WhatsApp works extremely well. Actually, it's the preferred channel for engagement. We understand there are certain risks and certain limitations. It's not ideal. We have seen some other vendors introduce teleconsultation solutions. Obviously, the jury's out, and we do respect the enormous amount of work to launch an application in the market. In some instances, the choice of app is driven by the payer. So if, let's say, your insurance or your employer says this is the app you would use, then that is what you must use to get a valid teleconsultation or a valid stuff. And so there is that dynamic that a third party may dictate what you have to do. And in that instance, as the beneficiary, if you are insured, then you have to do that. So it is always a constant struggle. Well, my insurance would only accept this app or that service, and we kind of have to fit into that. At the community level, really, I think ultimately the winner right now is just the phone call, and not necessarily an app. And most people have the ability to make a phone call in this day and age.
Yeah, I would echo that, Mocha, that it really is phone calls that we've realized are often the most successful. As simple as it sounds, it's just the most accessible for the biggest number of patients, regardless of, and of course that has its own limitations as well. So that's another thing that we're also in the process of determining. So what the actual scope of care that can be delivered over something as simple as a phone call.
Thank you all for your tough lines. We're getting close to the top of the hour, so I guess want to shift to what are the surprising outcomes. I think we've covered a lot about that already. What are the surprising outcomes of this shift to home-based care, and sort of what aspects of this shift do you see continuing, past COVID? And so what are the long-term implications of this shift? Closing thoughts in that area.
So I would say, Jude, that for us, one of the surprising outcomes is that even if a patient does not set a foot in one of our centers or clinic, we now have the ability to make sure that they get the right medication and the right care. And actually, I would like to share, there was a patient that lives in Tijuana, which is in a city that we do not have a clinic. And for one reason or another, he joined the clinic, and we virtually consulted him for 5 months now. He started in the first month with an A1C of 12%, and after 4 months, his A1C was 7.2%. So for us, it has been very surprising that we have been building all this know-how, and our doctors are now very experts in terms of diabetes, since we are specifically focusing on diabetes, that we do not need a patient come to a clinic to make sure they receive the specialized and adequate care that they need. So for us, that was very surprising. It's a very good outcome for the patient, and also it gives us a lot of good thoughts going into the future in terms of how many patients we can actually impact through this model.
Thank you, Miguel. Anybody else have any thoughts on sort of the long-term implications of this?
Jude, maybe let me just throw something. So I think one of the things we realized when we started implementing home-based care, we had a mobile app called Jitenge. But then we didn't use it for quite a long while, because what we soon realized were issues around the data protection, and this is something nobody had thought about, because obviously the app collected a lot of your information, including your locator information, where you live, who are your contacts within your home. And of course, your daily, you logged in your daily symptoms onto the app. But then we soon realized this could not go on, because I think there needs to be some very good legal framework as we introduce these apps to ensure that the patient's data is protected, and there is no possibility of a hacker getting in and stealing that data for whatever reason. Of course, we had all sorts of people who are on home-based care. We had very high-level officials in government who are on home-based care and been monitored using that mobile application. So again, I think as we think about these different innovations, telemedicine and everything else, then it's critical that we also look at the legal framework to ensure that our patients' data is protected all through. Because right now, even the clinical teams in the different clinics now understand that it's taking care of patients at home obviously has potential to increase or improve the outcomes for most patients, rather than having a patient going to the facility or being admitted for something that could have easily been taken care of at home if the caregiver is well informed. So I think the issue of data protection is something that we continuously have to think about as we think of scaling up all this good work that has been done.
Great, thank you.
Very quickly from my end, the two things. First and foremost, I think the pandemic, the way it played out in the East Africa region, and I would say broadly in the global South, is that I think there was an expectation that there would be a bloodbath. The mortality rates would be very high. And so I think the global health community is a little stunned. What happened? What happened? And there was a huge mobilization of resources to prepare the isolation wards and the units, and a lot of public health dollars went into that. And the mortality rates, have not surged as had been anticipated. So in a way, there's still no clear guidance. And I say this because patients and people are asking, should we take it seriously as we are resuming work? Do we expect a second wave, or is there some inherent immunity that we're expecting? And so the sooner that the global health community can rally around that notion of this is what we thought would happen, but we seem to have gotten out of the crisis much better than anticipated. What are the lessons learned? To be learned? I think that is one question that we must make some effort to answer the global health within the global health community. Secondly, is this pandemic has shown that a lot of the disease burden is attributed to poor disease management and prevention. To see an 85% drop in utilization across board. And that is not only in infectious diseases, but in chronic diseases, shows to what extent lifestyle is affecting disease. And if we want to stay true to the notion of prevention is important, then there is a lesson to be learned. And what do we as now service providers that relied heavily on 25% caseloads for upper respiratory tract infections and skin infections and gastroenteritis, what do we do going forward? Our business models in jeopardy? I think those are open and raw questions that at some point we need to embrace and come to terms with at a fundamental level.
Indeed, indeed. Lots of shifts going on. I invite anybody. We are right at the top of the hour, so if anybody has any quick questions for our panel. Otherwise, I'd just like to take this opportunity to thank all of you for joining us this morning or this afternoon. I think we had a really informative discussion. I think learned a lot of interesting things about innovative approaches that you all are taking to reaching your constituents in the context that they need and coming up with innovative solutions for them and the surprising implications of these shifts as far as opening new markets and finding new ways of addressing their needs. I think that this obviously there's challenges around COVID, but it seems to have also forced a shift in outlook on both the provider and the patient side as far as what it means to access care. But there are going to be some long-term implications that need to be addressed, some challenges as Dr. Linton pointed out as well. So I'm just looking at our session. It looks like everybody's saying thank you as well. So great discussion. Hope all of you continue to stay safe and thank you again for your participation.
Thanks, Judd. Most appreciated.
Thank you so much.
Yeah.